Hello, everyone. Welcome to our session of the National Pancreas Conference on Neoadjuvant Therapy. I'm Jessica from Craig's Cause Pancreatic Cancer Society, and I'm delighted to introduce our speaker for today, Dr. Niraj Gusani. Dr. Gusani is Chief of the Section of Surgical Oncology at the Baptist MD Anderson Cancer Center in Jacksonville, Florida. In this new role, he is helping to build a team devoted to multidisciplinary care of all cancer patients in North Florida and beyond. His active current focus of research involves the role of physical activity and prehabilitation in the outcomes of patients undergoing gastrointestinal cancer surgery and in cancer survivors. Other research interests include epidemiology and patterns of care in gastrointestinal malignancies and the measurement of quality and costs of care in oncologic surgery. Currently, the only potentially curative treatment for pancreatic cancer is surgery. However, pancreatic tumors are only considered operable or resectable when the malignancy is detected in its early stages, before metastasis. Given the vague and late presenting symptoms of pancreatic cancer, early diagnosis is rare, reducing the accessibility to curative treatment. Neoadjuvant therapy approaches aim to decrease tumor burden and grant more patients the option to undergo potentially curative surgery. This session will educate participants on current practices in neoadjuvant therapy, as well as ongoing research which aims to increase access to curative surgical treatment and improve outcomes for later diagnosed patients. So please join me in welcoming Dr. Niraj Gusani.
So my name is Niraj Gusani, and the introduction was delightful. I recently moved to the Baptist MD Anderson Cancer Center in Jacksonville, Florida, where we're in the process of building a program to take care of all manner of advanced surgical cancer patients, but especially pancreatic cancer, which is one of my focuses and one of the things I most like to take care of. I got interested in this field very early on in medical school, just seeing some of the amazing abdominal operations for cancer that were being done by some luminaries in the field way back then, and the difficulty and the challenge of pancreatic cancer surgery was something that it just caught hold, and I've never lost some of that wonder ever since. And so I'm delighted here to talk about neoadjuvant therapy. It's really funny that a surgeon would be talking about non-surgical treatments, but really these are critical in our multidisciplinary management for pancreatic cancer. And you've heard all throughout the conference about how important it is to have a team taking care of these patients. So you saw the objectives from regard to the neoadjuvant therapy portion. We'll talk about a few other things because I think it's important to talk about surgery and some of the other things related to that so that we can better understand how neoadjuvant therapy plays a role. So we'll define some of the indications for the multimodality and surgical treatment of pancreatic cancer. We'll review some of the advances in preoperative evaluation, perioperative care and treatment strategies, and surgical techniques as they relate to pancreatic cancer. And we'll discuss both surgical and oncologic outcomes, and some of the data on long-term survival, which is still elusive, but increasing, thankfully, slowly but surely, due to efforts of so many people in pancreatic cancer research and treatment. So I want to give you the backdrop. I think most in this audience will already know about pancreatic cancer. You're here for this reason because you want to learn more about it. But we'll talk about the demographics, the overall poor prognosis, the fact that late detection, unfortunately, is still the norm, and so many other factors which make this such a hard disease to find and to treat. We'll talk about how our patient has multiple strikes against them before they ever even get diagnosed with pancreatic cancer, and certainly before they're ready for treatment. And we'll talk briefly about nihilism, about both surgery and about treatment in general, which actually drives a lot of the outcomes, unfortunately, which we all need to change, and all of us being here today hopefully will help with that. Finally, multidisciplinary treatment is the norm in all cancer care, but it's most important in advanced GI cancers where patients have a difficult tumor to treat and it's often presenting late. We need a whole team dedicated to the treatment. And we'll talk about how tumors can be borderline or locally advanced. We'll talk about what some of that means and how this neoadjuvant therapy paradigm, many of us think, will change the field in terms of our ability to help pancreatic cancer patients. So these are the statistics from south of the border in the United States from 2019. So in fact, now in 2021, we are seeing over 60,000 cases of pancreatic cancer every single year in the United States. It barely cracks the top 10 in new cancer cases, as you see here. However, pancreatic cancer is a huge cause of cancer death, and that's because the overall outcomes are still very poor and most patients present late. In fact, this is a statistic you never want to see for your favorite cancer in the news, but a lot of us get our medical information from CNN, so I think it's important to pay attention. Pancreatic cancer was reported by CNN to have surpassed breast cancer in 2016 as the third leading cancer killer in the United States, similar in most Western countries, and will be the second leading cancer killer by the end of this decade. And you can see the steep line for pancreatic cancer deaths going upwards, unlike many other cancers where we've started to make a dent and are lowering the number of deaths. So these are the trends since the 1970s up until 15 to 20 years ago, and continues today, of single-digit survival at 5 years for pancreatic cancer. Currently, we're just scratching 8 to 10%, depending on who you read. But as you can see from the graph, pancreatic cancer has the worst prognosis of any solid organ cancer, bar none, and really presents a great challenge to all of us in terms of trying to improve outcomes slowly but surely. So what is the challenge of pancreatic cancer? We all know this. Unfortunately, there's no screening test. The incidence is so low that a screening test for the general population, even if we had one, would run the risk of a lot of false positives. We'll talk briefly about some things which can help us maybe detect pancreatic cancer early, but really we don't have it yet, a way to screen the population. Late appearance of symptoms, which we'll talk about. By the time we realize that this visceral organ in the back of the abdomen is causing problems, it's often too late. And finally, rapid growth and spread, which results in metastasis very early in our patients and spread quite quickly. Our friends in the UK have these wonderful infographics from one of the pancreatic cancer societies that they talk about. November, as you know, is Pancreatic Cancer Awareness Month, and it is important to know the signs of pancreatic cancer: abdominal pain, bloating, jaundice, changes in the urine or the stools, itching, malaise, weight loss, and so on. Unfortunately, these are protean symptoms and can much more commonly be a result of other problems of the GI tract or of the abdomen rather than from pancreatic cancer. And so patients will ignore them, or physicians will not quite hit upon the diagnosis through no fault of their own, but common things are common and you look for those first. So pancreatic cancer is diagnosed late because of all this. There are a few things that'll help us, hopefully over the next decades, to catch pancreatic cancer early. So we now have a very good understanding of pancreatic cysts. This is a cartoon from JAMA from a few years back that nicely depicts the different types of pancreatic cysts. There are many more, but these are the common ones. Pancreatic cysts can be precancerous, and we're finding them more and more. I have 5 to 10 patients in my clinic every single week who have an incidental finding of a pancreatic cyst found on routine imaging for something else. We do CT scans and MRIs so commonly. So we all need to know how to look at these cysts and figure out which ones are the bad actors. We know that mucinous cysts, the mucinous cystic neoplasm and the IPMN, do have a risk of degeneration to malignancy. And so knowing which type of cyst we have through cross-sectional imaging and through endoscopic ultrasound and aspiration of the cyst fluid as needed can really help us pinpoint the type of cyst, and the ones that are mucinous can be considered precancerous. Sometimes they need to be followed, and sometimes we actually can prophylactically resect parts of the pancreas to prevent cancer. Finally, the story about new onset diabetes is becoming more and more prominent. So we all know that diabetes is very common, and as we get older, many of us are at risk for type 2 diabetes. But the combination of new onset diabetes or worsening diabetes, a certain amount of weight loss, and a certain age can help us put together a risk score. Dr. Chari, previously from the Mayo Clinic and now at MD Anderson, has done a lot of this work, but many others have as well. And so we're starting to enrich the population and figure out if you've had worsening diabetes or new onset diabetes at an advanced age with weight loss, maybe we should worry about pancreatic cancer. And this lets us enrich the population. We talked about how there's no screening test for the general population, but if you have a population that is a high risk for pancreatic cancer, then your screening with MRI or endoscopic ultrasound can be effective at finding these cancers early. And so we're starting to develop screening protocols for these patients. So again, let's look at our GI cancer patient. It can be a surgical patient in my clinic or really any patient who shows up with GI cancer. They're often elderly. Most patients present greater than 7 years old. They have multiple comorbid conditions, hypertension, diabetes, heart disease, et cetera, et cetera. They tend to be frail with a decreased activity, with sedentary and obese behavior, habitus and sedentary behavior. So they don't move around a lot, and so then it's harder for them to do so if we even ask them to. Then they're debilitated by the recent onset of their illness. They have severe GI complaints, weight loss, jaundice, all the things we talked about. Then they undergo a series of difficult, sometimes diagnostic procedures with biopsies and so on that can have complications. Then they finally come to you after all of this with a cancer diagnosis, and they know they're facing an uphill battle with multimodality treatment and a poor outcome. And so it's very daunting to take care of these patients. Add to that, I would pose to you that nihilism about pancreatic cancer is another thing that we really struggle with. Negativity and nihilism makes a lot of people, even with early stage cancer, never even see a surgeon. So this is a paper from 2007, so 14 years ago now, looking at the National Cancer Database in the US, and patients with early stage cancer who had surgery had a survival benefit. There were some long-term survivors. We know this is not everybody, but with early stage pancreatic cancer, we can cure you with multimodality treatment. But if you weren't offered surgery or didn't undergo surgery, even stage 1 patients had a very poor survival, similar to those with advanced stage cancer. And so we know that getting patients to a multimodality clinic and to a surgeon is critically important in all patients with pancreatic cancer. We all believe that medical progress is happening every decade and so on. So I looked recently, and unfortunately, this same curve was published in 2018 by another group looking at patients who didn't have surgery for early stage pancreatic cancer having just as bad outcomes as those who had no treatment or who had advanced stage cancers. And so we're not really making a dent in the overall nihilism and negativity about pancreatic cancer treatment, and we need to do better with venues like this today. So before we get to some important concepts about surgery and neoadjuvant therapy, let's talk about how we are doing better for our patients over the years. So our patients in the middle, I'm a surgeon, so I put the surgeons at the top, but we know that all of the physicians involved in care of these patients are critical, and so our friends in anesthesia and the ICU help us better take care of patients. Our colleagues in gastroenterology and radiology have improved techniques for diagnosis and even therapy of early stage lesions, pain control through celiac plexus blockade, interventional radiology for when we have a complication after surgery. All of these things are helping us take care of patients. Our friends in medical and radiation oncology have made huge leaps and bounds in terms of their treatment options, better drugs, better technologies to target the drugs, better radiation, precision medicine, immunotherapy, all of which is helping us get better outcomes for our patients. So just briefly, we know that patients with early stage pancreatic cancer need surgery as a part of their curative treatment, potentially curative treatment. We used to say that surgeons' hands were the only ones that could cure pancreatic cancer. We should never have said that, but we don't say it anymore because we know it takes a team. And I'll pose to you that the medical oncologist hands should treat the patient most of the time before the surgeons do. But we need to know about these operations because the operations for pancreatic cancer are a big deal. They're major interventions, and we know that there's a volume outcome relationship. So this is a seminal paper from 20 years ago now saying that hospitals and surgeons who do a high volume of pancreatic surgery get better results. So simply having a team, it's not these hands that help, but it's having a team that can take care of the pancreatic cancer patient can reduce mortality fourfold in high volume hospitals compared to low volume. And the relationship in pancreatic cancer was steeper than any other major cancer. So this is our patient, KH, who presented to us about 15, almost 20 years ago now, when I was working at Penn State College of Medicine in Hershey, Pennsylvania, who presented with this hypodense lesion in the pancreatic head. And I won't bore you with all the details, but this was a pancreatic cancer. And when we look at the scans, this person had all the hallmarks of a pancreatic cancer with biliary ductal dilatation, pancreatic ductal dilatation, so the classic double duct sign, a hypodense mass in the pancreas, dilated gallbladder, evidence of inflammation around the gallbladder. And here, this patient had significant abutment of the superior mesenteric vein. So this mass was right next to one of the veins that drains all the blood from the upper GI tract to the liver. Back then, we didn't know what we know now about neoadjuvant chemotherapy. So this person underwent a Whipple procedure. And those of us old enough know about the commercials from Charmin. This is Mr. Whipple who told you not to squeeze the Charmin. When I first learned about the surgery for pancreatic cancer, I thought it was him, but it actually was Dr. Whipple, a surgeon from Columbia who helped, with many other people, revolutionize pancreatic cancer surgery and make it possible for our patients. The Whipple procedure for pancreatic head cancer is a major operation where we remove multiple organs, including the bottom of the stomach, the first part of the intestines, the pancreatic head, and the bile duct and gallbladder. We have to do a complex reconstruction with multiple steps to restore enteric continuity. The whole thing takes half a day to a day, depending on how stuck things are, and it's a major insult to the patients with a chance of major complications. So even in high volume centers, morbidity, so complications after major pancreatic surgery are as high as 40%, and we expect that. We get patients through, meaning there's low mortality, but we have a high chance of complications. So that will play a role, you'll hear when we talk about the neoadjuvant therapy story in just a little bit. So 40% of patients have complications, delayed gastric emptying, which means their stomachs don't work, pancreatic duct leak or bile duct leak, which means that you have leakage of caustic enzymes or bile into the back of the abdomen, causing other problems. Many other complications are possible, and so these are major operations with major risks. So the New England Journal published a nice paper looking at the spectrum of pancreatic cancer, and it's important to look at these different things because we know the pancreas sits right near some major blood vessels. We know that the blood vessels can get involved, just like our patient KH, very early on in the course of pancreatic cancer. So progressive amounts of vascular involvement going up on the scale on the left suggests a worse cancer. So you can have distant metastasis to the liver or lungs or peritoneal cavity, but prior to that, even localized tumors can have arterial encasement or arterial involvement, making them unresectable. They can have venous involvement, which can make it a harder operation. We'll talk about that some in just a minute. Interesting that the New England Journal, one of the best publications in the world, still got the anatomy wrong on this paper, so I had to replace it with a old slide from a different anatomy textbook. The mesenteric vessels here run right under the pancreas, and so remember, a tumor in the pancreatic head here can very quickly involve these vessels right here. That's what we're usually talking about with vascular involvement. So we talk about these tumors being borderline tumors, and our friends at MD Anderson in Houston, the mothership of MD Anderson, really have done an amazing body of work over the last 15 to 20 years, looking at all aspects of these tumors and how neoadjuvant therapy can benefit patients with these tumors. Dr. Katz, one of my colleagues from MD Anderson, wrote a nice paper called talking about borderline tumors in 2013, those that involve the mesenteric vasculature and those for which resection, while possible, would be potentially compromised by a positive margin in the absence of preoperative chemotherapy. So we know that in a lot of other tumors, shrinking the tumor before surgery can help us do a smaller operation. And it's the same thing in pancreatic cancer. So these tumors that are involving the vessels, if we can shrink them, we might be able to get them away. And we'll talk about that a little more in just a second. The NCCN, National Comprehensive Cancer Network, publishes guidelines which many of us use to talk about vascular involvement, and they have a complex definition. You need a good radiology and surgery team to sort of determine this. I think that determinations of borderline or unresectable tumors should be done by surgeons in combination with radiologists, so it's important to look at all these things to determine this. But there's more to the concept of borderline. It's not just anatomical. There's patients who are borderline. So remember, we talked about our pancreatic cancer patient, GI cancer patient, having multiple comorbidities, being frail, being obese, sedentary, elderly, and weakened by their disease. So we know that type A borderlines are the anatomic borderline patients, the ones with vascular involvement, just as we talked about. We consider type B, this is again from the MD Anderson group. Type B is those with concerning biology. So if you have small lesions in your lung and we can't tell for sure whether they're cancers or not, they're too small to biopsy, but we're worried about indeterminate lung lesions, maybe this is considered borderline, maybe this is somebody who would benefit from chemotherapy. If you have liver lesions, same thing. If you have a high CA19-9 tumor level, marker level, which we'll talk about it more in a minute, that can be suggestive of worsening disease, maybe somebody who benefits from chemotherapy. And finally, patients who have borderline performance status or questionable medical conditions, those who can benefit from a period of time where we improve their medical state. So bad diabetes that needs to be controlled, poor exercise status, some heart medicines that need to be optimized. All of this can be done in a short period before surgery, hopefully, and make surgery safer. So we talked, I always tell my patients that the major surgery that I'm going to do is a big insult to their body all at once. But with chemotherapy, it's a huge insult to the body, but it's a little bit at a time. And so we can sometimes get people through chemotherapy, even with a lot of these medical problems, with careful management. So doing that up front makes sense. Try to optimize the medical conditions while they're getting chemotherapy. Let the chemotherapy wash out and get the patient strong and ready for surgery afterwards. So our patient had abutment of the SMV, and at the operation was noted to have involvement of the SMV, and so required a resection of this vein. I'll show you some cartoons that show this. This makes the operation, while it's still possible, while you can still get good outcomes, it makes the operation a lot more complicated, more chance of blood loss, and as we'll see, increases morbidity from the operation. And so here's an example of a tumor involving the side wall of the vein. We can patch up the vein and sew it up, or we can put a vein patch. Tumors that have more of involvement maybe require a piece of the vein to be removed and sewn together, or a patch from another vein taken. These add to the surgery because now you're doing blood vessel work. You have to clamp the blood vessels. You can have more blood loss, etc. You have to thin the blood to allow this not to clot. So these are some of the types of vascular reconstruction, and there's a sort of a sequence of these things depending on how bad it is, what you need to do to fix them. We do this all the time. Major centers, we're doing 20, 25, 30, 40% vein resections. However, we choose not to. We'd rather not do it if we didn't have to. So if we can shrink the tumor and not do a vein resection, we'd always rather do that. Let me talk briefly about the other pancreatic operations, just so you get a flavor of these operations. The Whipple is the granddaddy of them. But what if you have a patient with a tumor on the other side? This person was found with a breast cancer workup, found to have a pancreatic tail mass, hypodense lesion in the tail right near the spleen. For this, We can do a resection of the left side of the pancreas or the distal pancreas. You mobilize the pancreas and then remove the tumor, usually with the spleen and the lymph nodes. This is a procedure that involves a complex operation, but not as big of an operation as the Whipple procedure, mainly because there's no reconstruction here. You take this part out and then you're done with the operation. These patients still have a high morbidity, but it's not as big of a physiologic insult. Still a chance for leakage from the pancreas because we're having to cut the pancreas, chance for other complications in that organ space. The way we do this operation, we need to get good lymph nodes, so we have to go all the way back on the other organs in the back of the abdomen, the adrenal gland and kidney, and so sometimes additional organs have to be removed. Most of these operations are done minimally invasively now, so we do the exact same operation. We have a tumor here in the pancreas, stomach is reflected up, similar to that picture I showed you, ultrasound to define the pancreatic borders and where the tumor ends, then we get around the pancreas here, and then we remove it just as we did in the old days open. Now we can do most of these minimally invasively, so that it cuts down on the morbidity from the surgery, some of the pain, but it's still the same big operation on the inside. What happens if the tumor is more involved? Sometimes here you have a tumor that's involving the blood vessels in the back of the abdomen, namely the arteries. Even here we have options. We have a procedure called the Appleby procedure where we can actually take major vessels like the celiac arterial axis out. As you can imagine, this is a much more significant procedure, major vascular reconstruction. It is doable, but with a lot of increased risk to the patient. Here's the tumor again. Having to take out these blood vessels in the back of the abdomen requires a complex vascular reconstruction much of the time. Here's what it looks like after you remove this. The major vessels in the abdomen are essentially skeletonized. I always take a picture from the book and then take one from our own work just so you show people that you're doing a similar operation. You can do a total pancreatectomy. For a really bad cancer, you can take out the whole pancreas. Again, adds to the morbidity. Patients require insulin for the rest of their lives because they are diabetic, and in fact, they can have brittle diabetes. All of this is to say that we can do really big operations. However, the risk goes up as we do a left or distal pancreatectomy to a Whipple to a total pancreatectomy. The risks go up. And our group showed many years ago that these extended resections, if you take additional organs, if you take blood vessels, they add to the risks of morbidity, which is complications, and mortality, which is death from any surgery. So we'd always rather do a smaller operation than a bigger one. So we all have pathways now that define how to recover after surgery and how to treat the patients that help us get faster recovery and better outcomes. So we're doing a lot better with pancreatic cancer care, but it takes that teamwork approach. And now I'll tell you why I think neoadjuvant therapy is so important to this approach. So pancreatic cancer is a dismal disease. You heard the statistics, 10% 5-year survival at best. Most patients have metastatic disease at presentation. Even if we think the disease is localized, our best scans, show us only disease in the pancreas. We still think there's often micrometastatic disease at presentation, and we'll talk about this more in a second. So just presume that pancreatic cancer is almost always a systemic disease. We want to ensure that everybody, and I'll show you some slides about this in a second, gets multimodality therapy. So those who undergo surgery alone never get chemo, don't have a good outcome. Those who undergo chemo don't get surgery, never have as good an outcome. It's only with a combination of chemotherapy plus surgery, sometimes radiation as well, can you get the best outcomes and a potential for cure from pancreatic cancer. So if you have a morbid operation, it stands to reason that complications can limit your ability to get chemotherapy and other things. So we want to undergo multimodality therapy. You're more likely to get chemotherapy first and then surgery than surgery first and then difficult chemotherapy. With our chemotherapy, we can define those who are going to benefit. So we know that our best drug combinations, FOLFIRINOX, Gemzar with Abraxane, have some efficacy against pancreatic cancer. Not always, but often. And so if a patient is not benefiting from those drugs, usually these are bad actors. That means they're tumor is so aggressive that it's probably going to come back after surgery. So you can avoid a huge operation that provides no oncologic benefit. And patients always question this. They say, well, aren't we going to miss the window? If you operate, you're saying you can operate now, but you want to give me chemotherapy. If it grows, aren't you going to miss the window and not be able to operate? And I tell them that unfortunately, it's not the way it works. That usually just means that this is bad disease. And in fact, we're saving you a morbid operation that does no good compared to giving you an operation, that then you might recur just a few months later. We all have had patients who undergo these Whipple procedures. Maybe they have a good result and they recover quickly. Maybe they don't and have a complication, but a few months later they have lung disease or liver disease, and they die quickly from their advanced disease. And that's not recurrence from the surgery. It's tumor that was probably present that grew after surgery. And so we want to avoid the operations in those patients. Finally, if we can shrink the tumors and downstage them, we want to improve our R0. So R0 means resection with no residual disease. R0 resection is the hallmark of cancer surgery, getting all the tumor out as far as we know. If we can do that by shrinking the tumor, getting it off the blood vessels, we know that we'll have a better chance. When it's close to the arteries, we generally don't believe arterial resection is helpful, and so shrinking the tumor away from the arteries will definitely increase R0 resection rates. So here's some data to then maybe give you some food for thought. These are patients, this is a series looking at results in patients with different levels of CA19-9. Now we know that patients don't always produce CA19-9, but if they produce CA19-9, we took patients, or this paper took patients that had resectable disease, looked at their outcomes after multimodality therapy, stratified by their CA19-9 level. And really the question is, was it resectable or limited disease in those patients? You can see in the red and the purple, if you had a very high CA19-9, your survival was dismal compared to those who had low CA19-9 levels. And so really in those patients, you probably had systemic disease, and that's why you're going to recur early and you're going to die of your disease faster. The long-term survival to benefit, meaning the curve evening and flattening out, really only occurs in selected patients with intermediate levels of CA19-9 and often in patients with very low levels of CA19-9. So this, I think, is some of the best observational data we have for the benefit of neoadjuvant chemotherapy. This study came out a few years ago from the National Cancer Database, which captures about 80% of cancer patients from the United States. It is retrospective administrative data, so it's definitely not perfect. We'll talk about randomized trials in a minute, but this is probably the best data we have looking at neoadjuvant therapy, any type, chemotherapy, surgery, whatever, versus resection up front for pancreatic cancer that was deemed resectable. They looked at two groups, the neoadjuvant therapy group and the upfront resection group. In this time cohort, most people had upfront resection, and they did some propensity score matching to match the cohorts as best they can. You can never completely match these retrospective cohorts. But that being said, in this study, neoadjuvant therapy compared to upfront resection, so neoadjuvant therapy in the yellow, had a highly statistically significant survival benefit compared to upfront resection. And so, large study, many, many patients, retrospective, of course, but showing significant benefit in neoadjuvant therapy. We all know that randomized trials are the best evidence we have for treatment of cancers. And so what do we have in the way of randomized trials? And we're getting more and more data literally every year. This is a Japanese study looking at a combination of a drug called S1, which is not available in the US, but it's in combination with surgery here, so you get surgery alone with S1 afterwards, or neoadjuvant chemotherapy with Gemzar and S1 followed by surgery. And they had evenly matched groups, and they had 182 patients in the upfront chemotherapy group, 180 in the upfront surgery group. Significant difference in overall survival, 36 months in the neoadjuvant chemotherapy group versus 26 months in the surgery alone group. So you can see the curve separating, and you can see that patients who had neoadjuvant therapy did better. Now you can argue that there's a sort of a a bias here in terms of how they pick the patients and so on, but this is some of the best evidence we have for neoadjuvant therapy in early stage resectable pancreatic cancer patients. The PREOPANC study, this was an early diagram starting the study design, surgery up front, followed by chemotherapy versus chemotherapy followed by chemo and radiation, usually more chemotherapy, then surgery, more chemotherapy on the end. And so basically looking at surgery first, followed by chemotherapy or chemotherapy plus radiation first in the PREOPANC trial. And here, interestingly, there was a combination of borderline and resectable tumors, and in their intention to treat analysis, meaning if you really took all comers, they did not show a survival benefit here in the top left in terms of overall survival. There was a separation of the curves for preoperative chemotherapy versus immediate surgery, but this was not statistically significant. However, as we start to look at subgroups and disease-free survival, there was a clear benefit for chemotherapy. And more importantly, when they looked at the groups that actually got surgery and were able to get a surgical resection, R1 or R0, so a good surgery with minimal residual disease or completely free of tumor, there was a statistically significant survival benefit for preoperative chemotherapy. So again, when you do intention to treat, it wasn't significant, but in terms of the patients you choose for surgery and get a good surgical a good surgical operation, there was a benefit. And so this is, I think, gives us more to support the argument that if you do neoadjuvant chemotherapy, you can choose your patients better. Patients who you think aren't responding and you don't think you'll get a negative margin, maybe those patients shouldn't be undergoing surgery. Patients who have progression of disease or their CA19-9 doesn't come down, I'll show you a slide about that in a second, maybe they shouldn't undergo surgery. Surgery is morbid and has complications, and we could be shortening a patient's life by undergoing surgery when there may be no benefit. And so all of these data are pushing us toward this idea that this is a systemic disease. We should treat it systemically first before undergoing local treatments like surgery and radiation. This is the same curve from their preliminary analysis from PREOPANC. So here is a study from the MD Anderson group, now quite old, 7 or 8 years old, but they took all of their patients who had multimodality therapy, meaning they were slated to get chemotherapy and surgery and potentially radiation as well. We know that's what it takes to treat pancreatic cancer. If they were able to get all of their intended oncologic therapy. So intended oncologic therapy, IOT, is a sort of newer thing that we're looking at. If you're able to get all treatments, you get a much better outcome in terms of your overall survival than in the multimodality group that didn't get all their treatments. That stands to reason. If you don't get one or two of the pillars of your trimodality treatment, you're not going to do as well. The question really is, why did this happen? And as I'll show you in the next slide, more often than not, if you had surgery first and had complications, you didn't get your chemotherapy. If you had neoadjuvant therapy first and then surgery, even if you had a complication, you had gotten all of your treatments and you had a better survival outcome. So survival is not adversely affected if you have complications after neoadjuvant chemotherapy. It's definitely adversely affected in multiple tumor types, but especially in pancreatic cancer. If you have surgery and you have complications, you either don't get your chemotherapy or you may get it but not tolerate it, and or you may get it late and there's less of a benefit. Finally, it's really important to look at CA19-9 response in those that have an elevated level. We already know that super high levels are markers of micrometastatic disease. So if your CA19-9 is over 1,000, I'll do a diagnostic laparoscopy because I'm worried you have metastatic disease that I can't see on my scans. Even if you don't have anything obvious, I will still very strongly push to give chemotherapy up front. If the CA19-9 response is very high, so greater than 50%, some studies talk about greater than 90%, you have a much better survival than those who don't respond in terms of their CA19-9. So radiographic response in terms of pancreatic cancer is harder to measure. The stroma around a pancreatic cancer is dense and the tumor may not shrink. So we look at stable disease on imaging, but CA19-9 is very sensitive. So CA19-9 response strongly predicts outcome in pancreatic cancer. So if you've had a good response, I'm much more inclined to operate than if you haven't. Finally, pathologic response. So those who responded to chemotherapy, as you'd expect, those get the best survival. So major pathologic response is rare, 13% major pathologic response, only 3 to 4% complete pathologic response. But if you have those major pathologic responses, your median survival is greater than twice as long as those who didn't have those favorable responses. And so the response to chemotherapy, now this is of course has to be done, you can't measure the response until after surgery itself, but this response can predict outcome. And so doing chemotherapy up front and having a response measured by CA19-9 or measured by shrinkage on the scans is a very, very favorable situation for long-term outcome. So there are newer trials now looking at sequencing of the chemotherapy or type of neoadjuvant chemotherapy. This recently published study from the SWOG group looked at whether FOLFIRINOX or nab-paclitaxel, Gemzar with nab-paclitaxel, was a better regimen for neoadjuvant treatment in pancreatic cancer patients. They showed no difference and really gives us more fodder for the idea that whatever neoadjuvant therapy your patient can tolerate really is better than no neoadjuvant therapy at all. Finally, the data on the radiation story is much more complicated than we can get into here in a short talk. But in some studies, SBRT and focused radiation in this study did not improve survival. In other studies, radiation in the adjuvant setting after chemotherapy has some potential survival benefit, but it's really unclear. A lot of us use radiation in locally advanced or borderline tumors to sterilize the margin around the blood vessels before we operate. So tumors that have significant vessel involvement, I worry that our operation may leave a positive margin, and we'll use radiation after a period of chemotherapy to try to sterilize that area, and then when we operate, get a better chance of a negative margin. So we all know that November is Pancreatic Cancer Awareness Month, and I'll tell you that all of the research efforts and the clinical trials that are ongoing are critically important, of course, but just awareness and just the idea that pancreatic cancer is soon to be the second leading pancreatic cancer killer. I don't think anybody in the lay public would guess that. And so whatever we can do to sort of raise awareness, make our world purple, will help with that, and maybe reduce some of the nihilism and sort of the lack of patients getting referred. A lot of patients come and tell me, well, I heard that the treatment's worse than the disease. And while outcomes can be poor, we do have a lot of treatment options. So we're all going out there trying to raise awareness about this disease. So in summary, pancreatic cancer is a complex disease with poor prognosis. Improvements are occurring regularly, but really we have to fight this therapeutic nihilism, and we want this to become a thing of the past. Care of the pancreatic cancer patient clearly requires a unified, high-functioning, multidisciplinary team, and optimal outcomes will require more than just medical care. We need awareness and education and so on, but I would argue that the medical care needs to focus on that multidisciplinary team and pushing the chemotherapy first earlier in the treatment sequence. I think there's almost never a role for upfront resection in pancreatic cancer in 2021. We still do it on occasion, but it's rarely the case, and I think that's a good thing. I always, with permission, like to present a patient story. So remember, our goals of treatment in pancreatic cancer are not just to do the operation and get an R0 resection, but it's to get a good functional outcome and get patients back to their lives. So this nice gentleman was a pastor, a chaplain at a local hospital. So he'd been familiar with advanced pancreatic cancer patients. He had pancreatic cancer, he had chemotherapy, and then he had a Whipple procedure done, and he had a rough go. He'll tell you about some days post-op that he really felt like he wasn't gonna do well. But his goal after surgery was to get back to his normal functional life. He had been a big runner, and he didn't feel like running for the first several months after surgery. And I told him, look, my goal is to get you back to running, because that will make me feel like we did you some good. And so then he sent me this picture. I got a wonderful photo in the mail. Whipple surgery was a very tough road, even when all goes well. After that, he trained and trained, and I knew he was training, but I didn't know if he made it to his half marathon. But he completed his long runs and his half marathon, and he sent me this picture, and this was the best gift I'd gotten all year essentially from him. And so it's important that we can get our patients back to a full and complete life. Pancreatic cancer is a dismal disease, but there is hope with multimodality treatment and with teamwork and a multimodality team. So thank you all very much for the opportunity to present and to speak about this, and I'm happy to take any questions.